the consent? Perfect. Thank you so much. So moving on to our agenda today. So we'll just do a quick background about CST, our purpose and guiding principles, and the role of the SME. The majority of our time will be spent doing clinical requirements gathering, and then following up with some additional questions from the site and any next steps that we're going to be taking forward. So just quickly about CST, it is a clinical and systems transformation project, which aims to transform healthcare systems and processes to improve the safety, quality, and consistency of patient care. And they involve 3 of our health organizations, which is Vancouver Coastal Health, Provincial Health Services Authority, and the Providence Healthcare. So the driving factors of the CST project encompass a range of goals, including prioritizing patient safety, enhancing the quality and consistency of care, improving the health experience for both patients and the healthcare teams, and leveraging gathered data to support health systems, planning, research, and proactive care. So the ultimate aim is to enhance the reliability and sustainability of the information system by transitioning from outdated to a unified information system, which will integrate various other processes and facilitate the delivery of high quality patient care. Any questions? So the role of the SME. So SMEs are subject matter experts. They contribute as an expert and as a representative of the area to discuss workflows and recommendations for future state workflows. They understand and think strategically about processes and workflows within the clinical setting and are able to consider the requirements and the needs of the stakeholder groups across all health organizations. They are familiar with the health organization policies and documentation, as well as able to confidently make informed decisions within their area of expertise. So we thank all of our subject matter experts today for joining our session. So we're just going to jump right into clinical requirements gathering. And we invite you to join in from the site. So we'll start off with our provider questions here. So what we currently know with providers for the clinic is that there are consults, follow-ups that are done via telephone and telehealth or as outpatients that are completed in the clinic. Medication reconciliation is also completed with each clinic visit on paper form, the patient's prominent profile. So just jumping on to some questions about that. Dr. McGrath, welcome. Thank you. Good morning. Thanks for joining. We're just going to ask a few questions about your workflow. If you're able to currently describe your workflow and take us through that.
You mean, sorry, my workflow as a physician, just myself?
Basically in the clinic. So I guess from the point of receiving notification that you're going to see this patient in the clinic, does that come from the nurse, right? They do their telephone visit and then they let you know after they've screened the patient which patients need to be seen? Or how is that communication done? Yeah.
Well, yeah, essentially Lana will screen the patients, and if they're accepted, they then get booked in automatically with a physician. Could be myself or one of the 4 other physicians that work in the clinic. So that would be a consult, and it'll be booked for 1 hour. And most of the time, by far most of the time, there's already been, Lana has spent an intake session as well. Occasionally, if we're having trouble getting patients booked in or it's urgent, then they may come directly to the physician before Lana's done her full intake session. But yeah, how would I get notified? I would get notified by Grace, who is our clerk. Grace builds the clinic roster for the day and then sends me a PDF email file that shows the slate for that day, usually a few days in advance.
Perfect.
So
and you said you share it with other physicians. Are they all anesthesiologists by background?
No, I'm the only anesthesiologist. They're all pain specialists, which is kind of like a subspecialty. So 2 of them are psychiatrists that have done pain medicine training and also addictions training. And the other 2 are physical medicine and rehabilitation specialists who've also done a pain medicine specialty.
Okay, got it. So you get booked for the consult, you get the slate. After Lana screens them, do you see all the patients in the consult, or how is it determined which person this person's going to see, whether it goes on your slate or whether it goes on the psychiatrist's slate?
Well, most, like on the first level, it's by availability, whoever's got some availability in the clinic.
Okay.
However, some of them might be triaged specifically to one of the psychiatrists because of perhaps significant mental health challenges or significant addiction concerns, usually more addiction than mental health. So they might be then channeled towards one of our psychiatrists, but that's a bit of a judgment call.
Based on Lana's judgment, based on the screening? Yeah. Okay.
Yeah, based on her screening, but she may also just talk to one of us.
Got it. So basically Lana will do that kind of preliminary talk with the patient, determine who they think is most appropriate, or who Lana thinks is most appropriate to see, maybe consult with you a little bit if there is a question. And at that point, communicates with the clerk, who would then book it on the appropriate person's slate based on availability or who is most clinically relevant to see the patient.
Yep.
Okay. That makes sense.
Lana, if I make any errors in how I understand it, please just jump in.
Thanks.
And then do you guys have like a rotating schedule? Are you there Monday to Friday, or are you there certain days every week? Dr. McGrath?
Yeah. Each physician typically has their own half clinic day. So we have 3 days a week that the clinic is available. So the other 4 physicians all have a half-day clinic that's kind of like their time slot.
Yeah.
I have much more flexibility in my schedule because I'm working part-time. So I tend to either fill in for somebody who's away if I can, or schedule my own time, which is usually a Monday morning. Yeah, that's pretty much it. I'll work Monday morning or fill in for somebody else.
Okay. Yeah, I'm just trying to picture how, because basically in the system, there's going to be books to schedule too, and then they'll have resources. So we could kind of split it out between you guys to kind of know which one, but we can block time. So if you guys consistently always do like a Wednesday or a Thursday, then we can kind of set that up so it's clear for the clerk about what you're available for. Yeah, Alex,
Yeah.
I think you have a question. Sorry.
Oh, I was just going to chime in. Yeah, Alex, the OT here. I have heard Alana do some of these intakes, and one of the questions she's asked is, would you prefer a female doctor? And we have only one on the team, so I don't know if that's something you would need on Cerner as a checkbox of some sort.
Got it. Okay, that makes sense. So I think we understand. Go ahead.
Sorry, Amanda. This is Lana.
Hi,
All
Lana.
right. Hi. Alex, thanks for that. I think there's a little bit of misunderstanding around that female-male question that pertains to the looking or securing the GP form. This is not something I do ask in the triaging for our pain specialists. So,
Got it.
Yeah.
Thanks, Lana. Sorry about that.
No worries. Yeah, it's just part of the Vancouver Division practice package.
Perfect. Okay, Dr. McGrath, do you ever screen the chart prior to your consult visit, or is the consult visit the first time you look at the chart?
No, sometimes I do. I might, like I'm at home working from home sometimes, not usually for the clinic, but just I'm home more often than I'm at the hospital. So I may go on to Care Connect and read some stuff beforehand.
Okay.
I think the other doctors also do that.
And then do you work other areas of the hospital too? Do you work in the OR anywhere else, or are you just strictly in the clinic?
No, just in the clinic. The other doctors, both the psychiatrists, also both work on CPAS, inpatient complex pain and addiction service.
Okay, perfect. Yeah, the reason I ask is I just want to know if you need to have any other access to any other information throughout the hospital, but it sounds like just the clinic would be applicable to you at this point. Okay.
Yeah.
And then so you do your clinic visit, the patient comes in, you're going to do your in-person consult. Do you do any other telephone or telehealth as well, or do you just do the in-person for you specifically?
No, all of the above: telehealth,
Okay.
Zoom video, and inpatient, face-to-face.
Is the initial one always an in-person, or how is that determined when they're going to book?
It's mostly determined on the patient's preferences,
Okay.
and we will kind of go with that for the first visit. And then if any of us, like the physicians, I mean, if any of us feel like we really want to see this person in person, then we will request that they can come in.
Okay.
That's not always possible because maybe they're far away, in the province, and don't have other means to get in here. So it's possible they'll have their entire time in TPC
Okay.
video, but we try to get them in at least once to kind of just lay eyes on them and do a physical exam.
Okay, so it sounds like the first visit is always like a telehealth telephone visit with the patient. And then from that point, you'll determine whether or not they want an in-person visit unless they specifically ask for an in-person visit for the first one.
Yeah, no, they're not. It's not automatically a video or telehealth the first one. It's
Okay,
the
whatever.
very first visit is kind of like what they prefer. So
Okay,
I'm getting probably close to back to 50-50 right now, and sort of in person or telehealth.
okay. And Lana, that's based on your screening, right? You'll know at that point you ask them what they prefer. Is that where they determine the first visit?
Yeah, I just offer them, and I think when it's determined is when they connect with Grace. I don't do any booking, so that's where it's confirmed. I just provide them with
Got it.
choices. Yeah.
Okay, so Grace will be actually
Yep.
contacting
Grace
the
is the
patient
one.
as well after you to set it up, the booking, and then ask
Absolutely.
them. Perfect.
Yes.
Okay.
Yeah.
Lovely. And then after you see the patient, Dr. McGrath, do you have standard documentation that you always do? Is there like a standard note that you utilize, or is it a free text, or?
So, I mean, I'll take some handwritten notes just so
Yeah.
I can remember what happened, and then I will use Fessor to create a note, which I kind of created my own template for.
Okay. I think we'll follow up with you after this session, if that's okay, and get that note template, because that's something that you could still dictate into and that we could build in the system for you. Do
Okay.
you,
And also the other docs would all probably have their own method
Yeah.
of doing this too. Like it's not
Yeah.
a standardized TPC one.
yeah, that's okay. But if you have one that you continuously use, a template that we can try and build for you, that would be good. And then do you distribute that at all? Do you send that to the GPs or anywhere?
Yeah, so it's automatically sent to their GP, and
Uh-huh.
then I usually add copies to the relevant specialists who are involved.
Okay. Perfect. So then I think we've covered, you do consults, you do telephone, telehealth. Are there any other, you don't do any procedures or anything like that, right? In the
No
clinic?
procedures.
Okay. Is there any other appointments that you generally do?
No, I mean phone, but phone, just telehealth. So yeah. Can I just ask a quick question about distributing copies? And this maybe just something I'm missing, but it used to be when I was doing dictations, or just voice dictations. You could say send a copy to WorkSafe BC, blah blah blah, claim number. Now that's not really possible, as far as I know, with Fessor to sort of automatically send a copy to like institutions. It has to be sort of like a specialist. So is that something that can be built in as well?
I'm honestly not sure about the answer. Yasmin,
Okay.
do you know the answer off the top of your head? If not, we could take that back.
Sorry, could you repeat it again?
Dr. McGrath was
question.
asking if you could automatically dictate through Fessor and have it distributed based on like WorkSafe or wherever else it needs to go.
You can use Fessor into note into Cerner, and then we have a means of using Message Center, so you can message that out. It's kind of like CCing to WorkSafe. Rather than typing in a provider, you would type in, I think it's WorkSafe BC, and then the different locations show up. So there's different locations like Victoria, Vancouver, a few different ones.
Mm-hmm.
That's how it would go.
Thanks, Yasmin. Okay, so we asked about your documentation, we asked about your templates, we asked about your appointment types. Do you send standard referrals out inside and outside the hospital, or do you just refer within the hospital?
So it's not too often we might send a referral, but it does happen both within and outside the hospital. Like there's another pain clinic whose members, two of them that work in our clinic, also run this other pain clinic in the community, and they do procedures. So if we have some procedures to do, we might refer to them outside.
Okay, so both. And then do you give any standard forms to the patient, you personally, at any point? Any standard
I don't.
papers or?
I don't personally give them anything.
Okay.
There is intake forms that they do though.
Okay, and then you do the med rec, is that correct, when you do the visit?
Yes, when I do the med rec, like when
Okay.
I actually do it,
Okay,
meaning lots of the time I don't. And most of the physicians also probably do it less than half the time, finish completing it.
okay. Okay, that sounds good. And is there any other, you don't administer any medications, correct? You don't,
No, I don't administer. We might prescribe, but we don't
Yeah.
administer.
so give prescriptions?
Yeah.
You do referrals?
Yeah.
Do you have any standard pre-printed orders, like any that you have to give to Lana that you use currently? Like a standard order sheet?
No, we have an order. We have a written order sheet, just like what we used to have in the hospital that we
Yeah.
would use to communicate with each other. Like I'd write on there, then Grace would get that. You know, we might just verbally tell Grace like, "Hey, we want to do this," but there's we would just write on there. Although we are now creating an in clinic referral forms that the physicians would fill out to send to,
Okay.
you know, psychology, OT, or PT.
Right, that little form that kind of says you want them to follow up with OT or PT, and then you give that to the patient to give to the clerk, and then the clerk will book the follow-ups? Is that what you're saying?
Yeah, that exists, but no, I'm talking about something we're just actually creating right now, so
Okay.
that would be like a one-page form with sort of like why I'm referring to Angie, our psychologist, or why I'm referring to Sarah, our physio. It's just like a communication sheet.
Got
Sorry,
it.
can I, Amanda, can I ask about the medications, the prescriptions? Do you see patients from all over the province over Zoom? So do you use like
Yes.
Plexia use Plexia to send prescriptions, or do you fax them or
Fax.
fax? Okay.
Yeah.
Thank you.
Hi, Lana. I think you had your hand up.
Hi, I don't know if this is applicable to what we're talking about right now, but in terms of handing in forms to clients, occasionally we send or provide them with a urine screen lab requisition.
Yeah.
I don't know if that's applicable to share right now, as well as the
Yes.
neuropathic cream form that we have. And then I think that's about it, but I think Michael has mentioned the pain surveys, and that those are kind of sent as a link via email. So I don't know if they're to be stored within a CSD or how that kind of relates to that.
So the surveys, are they part of the clinical chart? Do you put them part of the clinical chart afterwards?
Yes, we do.
Okay.
Yeah.
And then the urine rec, that's fine. They could probably go to any Life Labs, right? They don't have to come in the
Yes.
hospital to
No.
do that?
That's
Okay.
correct.
And then the cream, is that a prescription? Or
Yeah.
okay.
Yes.
Yeah, we might either handwrite it, handwritten on a piece of paper, or
Yeah.
we have a form with sort of some tick boxes, like a, you know, I want this, this, and this, and the cream, that kind of thing. We might just give them that instead.
Is that for a specific pharmacy, or is that just generally any pharmacy?
No, any.
Okay. And then the form that you're creating, Dr. McGrath, with the communication piece, is that going to be part of the clinical chart, or is that just meant to kind of, once everything's booked and they've read it, it doesn't go part of the clinical chart?
I guess we probably leave it in the paper chart, but
Yes.
it's
Okay.
not, you know, once the referral is done, it's not really like we're going to look at it again.
Okay. Yeah, I'm just wondering if you want it in the system or not. If you want it clinically in the chart, and then if so, we can look at building that.
Yeah, well, I guess I don't know, because I'm not really sure how we're going to interact with Cerner. Like it's
Yeah.
I'm learning how to play a game of cards, but I don't quite know the rules yet, so I don't know.
Exactly. So we'll just gather all
Yeah.
your requirements, everything that you're doing now, and then the next session
Yeah.
we'll actually kind of show you some stuff and see what you think.
Yeah, okay. Just hang on. There was one thing I wanted to add about Nope, I've forgotten what it was. Something about what we were talking about, prescriptions or something. But
The creams, the tick boxes.
yeah, no, it wasn't the cream. I don't know. It'll come back.
Okay. Lana, do you still have a question?
No, sorry,
Okay,
I'm going to
no,
lower
good.
my hand.
Yeah, no worries. I just want to make sure. Okay, so we did hear that there might be a requirement to do an order set. So I know you currently don't have a PPO, which is like a current sheet that you check the same things off every single time. We're wondering if this is a requirement for you guys. Do you need a standard order set built? And what that means, it's something, Dr. McGrath, that is easier for you to place orders on. It's like a set of orders in one area. So you're not searching for each order each time. If you have standard referrals that you do every time, standard prescriptions that you order every time, standard care orders, if Lana needs any care orders, we could group those together in something called an order set. If you're just doing one-off referrals or one-off prescriptions, it probably doesn't require an order set. So I'm just kind of reaching out to see if you have standard orders that you do every time.
And just because you aren't familiar with the system, sorry to interrupt, they're not necessarily selected. So the list will be there and it's kind of like a tick box where you can tick what you need, or you can have some of them pre-selected as well. So it's generally a set of orders that you would usually use.
Yeah. It seems like that might be kind of interesting to have. I'm going to talk with my physicians about it. So
okay.
Yeah, I'm just still trying to visualize it. Like, so like right now, let me just walk through something. Right now, I might see a patient and then say, okay, we're going to start this medication and stop that medication. And I'm going to refer you to our physiotherapist and our psychologist within the clinic. And maybe we'll refer you to a procedure that's down the road, maybe not yet. So it might be kind of like that. And so I'm imagining, you know, that's all in our heads right now, and we'll just kind of do it. But I'm wondering, would it be like a pick list of things that we do kind of most often, and then we could just sort of pull that up and do it?
Yeah, if it's something that you consistently do all the time, then you could have that, and you can always add orders to it as well. So if you want to add orders to it, you can, but it's only helpful if you're consistently doing like usually the same medications every time. It's usually how you envision it, like a standard PPO. It would say like, nurse to do blood sugars QID, and then it would say like this medication PO QID, like because you're giving the same medication every time, so it just prevents you from having to search it every time. But if it's kind of sporadic, like you're doing a different medication kind of per patient and then it's different referrals, it's not as helpful because then you're pulling up something that you probably won't utilize most of the orders, if that makes sense.
Right, I see. And what happens to that order sheet then? Like say you do that, what is it for?
Yeah, basically you don't have to use it ever. So it kind of lives in the system. It's a standard something in the background. And then if you ever want it, you can open it up and utilize it and check off what you need. So you don't have to use it. Nothing happens with it if you don't use it. It's just helpful. Like if you're doing the same ordering every time, instead of searching for each order, it's helpful for people to have it in a standard order set in one area, that they're not looking for each medication, if that makes sense.
Dr. Negraff, if you want to take it back to your physicians, I was formerly on the provider adoption team, so I can actually, if you have like 15 minutes at some point in the next few days, I can just hop on Zoom and kind of show you so you can get a visual of what it looks like if you want to take it back to your team. That might help. It's a little hard to understand.
Yeah, sorry, it is confusing.
No, that's okay.
But if you want to reach out to me, I'm happy to show you.
Like I'm familiar with the inpatient side of things when you got a PPO for like heparin. It's kind of very standardized. Is that kind of like what you're talking about?
That's exactly what I'm talking about. I'm wondering if you have a standard set of orders that you want to be built in an order set like that.
I think, and there's one other question. Would each physician have their own, or it'd be like, this is the one for all the physicians for the clinic?
It usually should be one for all the physicians of the clinic. We usually don't build a order set for just one provider because it's a lot of work to maintain. So
for sure.
But what can be done is a bare bones version can be made, and then each provider can modify them, and they can add certain things or tick off certain things and save it as a favorite. And so there's like the base one that's for the clinic, and then you can customize it a little bit so that if your workflow is a little bit different than your colleague, you could work with that.
This is Joanne. I'm actually from the order set team within CST, and typically, just to give you a little bit more of a background, is that typically for clinics, there's lots of things we can do for power plans. So We can have labs in there that would automatically, you know, print out a requisition that you can then give to your patient or fax. We can have prescriptions in there as well for medications that you commonly use, which would also print out the prescriptions that you would sign and then fax. And amongst, you know, anything else you would want to particular order in patients, like you said, the urinalysis that we were talking about earlier, or any procedures and things that you might commonly do, referrals, as you mentioned, to OT, PT, psychologists, in sort of consults to other specialties, or just don't work within Cerner. It typically with power plans, we say, you know, consider consultation with XYZ, and it's still sort of the same consultation process that you would do now. But just about a bit of background, so a lot of clinics typically will create plans that have labs and diagnostics that require booking and requisitions, and prescriptions are quite commonly in those plans as well.
Yeah, it sounds like it might work for you, Dr. McGrath.
I can see as you're describing it more. I'll talk with the docs about it. I think they're probably going to like that idea, and it'll be like, here's like a bunch of stuff we often do. But I'm imagining too, you don't have to do everything on the order sheet. It's like you pick two out of the three things or whatever. Okay. And then what do you do with that? So you do that on the thing, and where does it go? Like, how does it then cause execution of the orders?
Yes. So depending on what you want to do with the order set itself. So if you have patients that are in person, you want to go to, say you order some labs and you want them to go to the lab at your site. Those labs would cross over to the lab side of things, and they would see them at their outpatient clinic. We can also build things out in the order set that will generate a printing of a requisition that you can then, you know, give to your patient or fax to your patient or email. The prescriptions, if there was prescriptions on the plan, those prescriptions would print out for you to sign and fax, you know, anywhere that you need to, or obviously hand to your patient. So when you sign the orders, everything within that order set, depending on what your workflow is and what your needs are, and we could talk about that more, things would work either, you know, printing and faxing, or they would go directly to pharmacy, or directly to, you know, whatever you need to happen.
Yeah. Okay. So it's customizable that way.
Yeah.
And I would imagine then we can use our like referrals within the clinic to our OT, our psychologist, that can all go on there.
Yes.
Yeah. And I think that's going to be helpful because I think you'll need the orders afterwards. So I think we'll get into the physio OT piece next. And then maybe, Yasmin, do you mind sending Dr. McGrath just some screenshots of test power plans, just so we get kind of an idea of what the order sets even just kind of look like, how they're structured?
Yes, we can do
helpful.
that.
Okay.
So I remembered what it was I wanted to say before we leave my stuff.
Yeah.
The questionnaires that we do, the pain surveys, the intake forms, and the discharge forms, those are, just wanted to let you know that we are using a UBC REDCap database, and those are generated within REDCap, sent by REDCap with an email link, and their data goes straight into REDCap.
Yeah, and you're not printing that out and putting it part of the chart now, right? Like currently?
No, we do print out the first batch of surveys just so that the physician who is seeing them for the first time and doesn't know them can look at those if they so choose.
Okay. So that questionnaire intake and discharge, it's all patient populated though, right? None of you are filling that stuff out. Okay. Nope. Perfect. Okay, so that's good. I think we covered the labs diagnostics. If you do any lab or diagnostic orders, Dr. McGrath, are you the one following up on them, or do you ever share that responsibility?
Typically we would follow up with that.
We talked about prescriptions. Do you ever direct admit patients? So do you ever see patients in your clinic and then send them up to an inpatient unit or down to ED?
Not usually to inpatient, although I guess that could happen. We typically, if there was something emergency, we would send them to emergency.
Okay. And then we talked about referrals, and we talked about who you refer to. Your billing, do you just get a label and then take it to your private MOA to
Yeah,
do billing, or how do you do your
we
billing?
just, yeah, I do my own billing with a billing
Okay.
service. Everybody
Okay.
does it a little differently. They might use their MOA in their private clinic.
Okay. Do you use any reports currently? Do you pull any reports?
Just say one other thing with billing, we also have a contract with the hospital for some other stuff. Is that going to be something we have to worry about with Cerner or not?
Oh, well, how do you do it currently? Do you just get labels and then do the billing afterwards, or do you?
Well,
bill
the
through
billing,
hospital?
so we bill MSP for the actual clinical visit, but there's some other funding we have from the hospital for meeting time and indirect clinical care that
Okay.
we send a quarterly report of hours and whatever that the hospital wants for us directly to the hospital.
Okay, is there anything that you would require from the system now to get that information besides a label?
No, we just track
Okay.
our own time
Perfect.
and time in, time out.
Yep. Okay. And then we
External
talked about the
reports.
billing. The reports, yeah. Do you pull any reports currently? Are you looking at any standard reports? Clinic times, type of clinics visits you do? Is there anything like that that you look at right now?
I don't think so. The only thing we do is use Care Connect and pull, like, could be labs or radio diagnostics or other physicians, reports.
Do you ever do research in the clinic? Research trials, research?
It's not got a strong program now, but we want to do more, like with our REDCap database and stuff
Okay.
like that. But we have not actually started, enrolling patients directly in prospective trials.
Okay.
More like
and then
QI, QA.
QI, QA. Sorry, what does that mean?
Quality assurance or
Got
quality
it.
improvement.
Yeah.
We might do like on the data that we're collecting.
Got it. Yeah. And then do you ever see any non-resident or uninsured patients?
It just came up as another question. Rarely, but it does happen.
Okay. Is there anything different that you need to do for that workflow? Or it's the same workflow from your perspective? It's probably different for the clerk.
Same workflow, just billing the person directly or through the
Yeah.
hospital would be different.
Okay. Now, is there anything else, Dr. McGrath, before we move on from you that you do that we need to know about, that you chart?
Yeah, let me think. Charting. No, I don't think so.
Perfect. Thank
Yeah.
you. Okay. So we talked about the order sets. Physiotherapists. So maybe Sarah, we move on to you. So it sounds like you get referrals from the same process, maybe either via LANA screening, thinking that you need physio, or by Dr. McGrath visiting the patient and deciding to refer you to physio. So how are you currently being notified that you have patients to see?
Right now I have an Excel sheet that Grace puts people in, and then she books them like a phone screen for me in my calendar, my schedule.
Okay. Do you triage these people from the Excel, or is anyone on the
Yeah.
or everyone on the Excel going to be seen by you?
I think the screen is kind of the triage.
Okay.
Yeah, the phone screen. Mm-hmm.
The phone screen is a triage by Lana, right?
No, sorry. Like they get referred to me, and then they get booked as a phone screen, and then I kind of triage them and chat with them on the phone, and that's kind of the triage.
Got it. So everyone on the Excel is going to get a phone screen by you. You're going to phone them, talk to them, and then you're going to determine if it's appropriate to proceed after that phone call with any other follow-ups.
Correct. Yeah.
Perfect. And then if they're not appropriate to proceed, do you just let Grace know, and then Grace will discharge them, or
Yeah,
what do you do if they're not
depends.
appropriate?
Yeah, so yeah, either I'll let Grace know, we'll discharge them, or I will often I'm referring them elsewhere, like if they're
Yeah.
work safe, or if they are like a joint replacement and they need to go to like a different health authority, outpatients or something like that. So often I fill those referrals out for them.
And do you get referrals coming into you for this clinic from anywhere else besides internally from this clinic?
No, just internally.
Perfect. Okay, and then you'll do referrals out. When you do the phone screening, after the phone screening, do you do any other appointment types? Would you ever bring the patient in for an in-person visit, or?
Yeah.
Yeah,
So I mostly do in-person or Zoom.
Got it. And then you would just, I'm sure, let Grace know, I've screened this patient. I want them to follow up, and then Grace will book those for you. Okay. And then do you use standard documentation for your phone call visit or your other visits currently?
Yes.
Okay, so we might just reach out to you and grab those in between these two visits to
Okay.
get those without any identifiers on it, just to kind of propose some future state options for you.
Sure.
Do you distribute those out currently? Do you send them to the GP or send them anywhere? Or does it just stay part of the chart?
I think it just stays part of the chart.
Okay. Perfect. So I think, is there anything else that you do in the clinic that we need to know about that you document on?
I don't think so.
Okay.
Oh,
Mhm.
hi guys, Andre here. I just have one question, Sarah. Do you guys do any outcome measures or anything
Oh.
like that?
Yes, we do. Yeah.
Okay.
So I use the PS, the patient-specific functional scale.
Mm-hmm.
Kind of depends though. It's such a varied population that sometimes I use, like sometimes we get concussion patients, so I use like the VOMs. So there are a few different outcome measures that I do use.
Okay. Would you mind put that together with the other forms? Thank you.
And then Sarah, you're never scheduling yourself, right? Grace does your scheduling?
Yeah.
Okay, perfect. And then are you the one physio of the clinic or do you share with another physio? The one
It's
physio?
just me.
Perfect.
Mhm.
Okay. Is there anything else that we need to ask you or add?
I mean, I guess the only other thing is, I don't know if this is different at all, but I'm going to be doing acupuncture. So I think
Okay.
that, I mean, I think I could just chart that like, you know, as a, like under documentation, but I don't know if that has to be a standardized, I'm not sure.
Yeah, if you just have,
mention it.
if you're just gonna like handwrite like a couple notes or whatever, we can do like a free text so you can type something out.
Yeah.
If you have a standard template that you want to utilize, you can send it our way too, and then we can
Okay.
give you some options.
Okay, sounds good. Maybe I'll look into doing a standardized template.
Okay, and then do you give any medications or anything like that
No.
in the clinic? Okay.
I just have one more question. Sorry, guys.
Yes.
Regarding the acupuncture, what about the waiver? Do you have a standardized waiver for the acupuncture in a way, or not really?
No, and we actually spoke with risk management and they said we don't need to do a waiver. We just need to get
Okay.
informed consent, but then we just need to be very clear with how we document on the informed consent.
Okay,
Which
perfect.
is why I'm
Thank you.
thinking maybe a template might be a good idea.
Yeah. Okay, thank you.
Perfect. Okay, lovely. So then maybe we can move on. So the next one, occupational therapist. So Alex, I think you're on the line.
Hello.
So same kind of workflow from what I'm hearing, that between the nurse screen or Dr. McGrath screen, you get the referral come through. Do you do the same kind of process as Sarah with the Excel? Or what's
Yep.
your process?
Yep, I was
Okay.
provided with the same Excel sheet. I'm new to the team, but I'm getting
Okay.
all used to everything that's going on here, and so far it's going well. And I do similar type of phone screen as Sarah
Okay.
does. And so we do have templates for that where I have like little check boxes or little notes that I write to make sure that they're an appropriate OT referral.
Okay.
And then that has indication at the bottom as to what the follow-up looks like. And
Yep.
when Grace reads that, she books in that client for me.
Got it. Okay, so that's the communication piece currently. So you're doing kind of like a checklist, phoning all the patients, doing a checklist, and then Grace will see at the bottom kind of what the follow-up is, and then she'll schedule off of that.
Yeah.
Note. Okay. Sounds good. And then do you have standard templates? So you said you had the checklist. Do you have any other standard templates when you see the patient?
Yeah, so I'm working on my whole initial assessment template.
Okay.
That's pretty much done. I'd like to think I'm still kind of trialing it with some clients, so I can definitely send that over.
Okay.
And then for regular chart notes, I'm usually just doing SOAP, so it doesn't need to be
Okay.
anything fancy, but that's kind of where we're at.
And then do you send that documentation out anywhere currently, or do you just keep it part of the paper chart?
Just the paper chart.
Okay. And then so you do the phone call screening. Do you do in-person visits?
Yeah,
as well?
I do phone, telehealth video, and in person.
Perfect. Lovely. Okay, and then do you do any referrals or anything else like that?
I think one thing, not so much like Sarah does the referrals, but I have been communicating with some stakeholders outside where I like email communicate with them, and I want to chart that email communication. And right now, sometimes I'm just printing off that email and adding it to their chart so that you can see what was written. So I don't know if that's something that I would
Yeah,
just copy and paste, or
are those people in the hospital? Or are they outside
Nope,
the hospital? They're in-
outside?
Okay.
Yeah.
Yeah. So that's going to be difficult to replicate if they don't have access to the system.
Okay. Yeah, I'm thinking that, I mean, I could also just chart it like a regular chart note to say, you know, email
Mhm.
so and so about.
For sure.
this.
Yeah,
Yeah.
for sure. Yeah.
Yeah.
Yeah. So is there anything else that you do that we need to be aware of that you chart currently?
No, I think that covers it all. The only thing I don't know with, you know, how easy it is for Grace, I just have her the paper chart and she can see easily when
Yep.
the next person should be booked next. I think that's
Yep.
the only thing to make sure that she's provided with that information
Mhm.
in an adequate way.
Yeah. Yeah, and we do. So we'll show you the next way. We do have a nice way to communicate that you need a follow-up and when you want it for and what kind of follow-up and stuff like that. So it kind of will fall on her screen to see that. So I think that'll be good.
Perfect. Thank you.
Perfect. And you don't schedule anything yourself, right? Grace does your scheduling for you.
Yes, she does.
Perfect. Lovely. Okay. So then, yes, thanks, Alex. So the psychologist, is it Dr. G or G or sorry if I totally
No, that's fine.
mispronounced her
Dr.
name.
G, yeah. Or
Dr.
Angie.
G, perfect, thank you. So we actually did get some of your forms through, so that was super helpful. So we've kind of screened a few of them. I do think quite a few of them have potential to be built in the system. And then some of them will remain on paper. For instance, if they require a physical wet signature, they'll need to stay on paper. So understanding your workflow, is it a similar referral process like they mentioned with OT, PT, in which you get the referrals either from Lana or from Dr. McGrath?
Yes, the only thing that I would add to that is our team is working on the referrals coming from the physicians only, but the team can correct me if I'm wrong on that.
Okay. Do you get referrals from anywhere else outside of the clinic?
No.
Okay, so it's all just within the clinic. So then you get the referrals. Are you kind of working off a similar workflow in which they're automatically booked for a phone screen, or what's your workflow like?
Yes, that's right.
Okay, so you get the phone screen. And then after the phone screen, is it the same kind of workflow where you're letting Grace know what you want to do next? What kind of appointment you need next?
That's right.
Okay. And then in your visits, do you have a standard note template that you utilize?
Yes, so that that intake report template that I think I
Yes.
sent to
Yes.
that's the one I usually use for 2 of my intake sessions.
Okay. So besides the forms that you sent us, there's no other forms or other documentation that you have, like other templates that you have. I think we got about 8 forms from you.
Yeah, the one that I just sent Lavilia now, because it came into my mind, is all the team will use a safety plan. So we have a safety
Okay.
plan
Okay.
that any of the team members can use. So I sent that over.
Perfect. And then the forms that you're utilizing now, do you just keep them part of the clinical chart or do you send them out anywhere?
No, they stay in the clinical chart, except one form that I don't think we've mentioned yet is we have an interdisciplinary report that all the
Okay.
clinicians write in when each of the respective clinicians have discharged the patient from their service. And then once the patient is ready for full discharge from the clinic, that interdisciplinary form would get forwarded to the family doctor.
Got it. And I think we saw that form. I think you sent it in with
Yes.
all kind of the areas. It's like a free text that they document on. So kind of signing off, I guess, from each kind of specialty perspective. So that's kind of what you utilize. You kind of pass it back and forth. And once it's all completed, that's when the final discharge happens. Is that correct?
Yes. Yeah.
Okay. And then that gets sent to the GP. Now, what about this intake summary? Is this a referral in or out of somewhere, this form?
No, that's my intake report. So that's the template that I use for the first 2 intake sessions.
Got it. So it's not a referral to somewhere preoperative or postoperatively. That's actually something that you're utilizing to document based on the patient visit.
Correct.
Okay. Got it. Do you do referrals out of the clinic anywhere else?
No, I'll often give the patient themselves. We have a community resource list with pain management and mental health resources. And so they'll take a look and access those services as needed on their own. I don't do referrals typically.
Okay. And sorry, you're a psychiatrist, not a psychologist, right?
Psychologist, not a psychiatrist.
Psychologist, not okay, so we did get it right. I think I thought I heard psychiatrist, and I was like, oh, I thought it was psychologist. So, okay, good. So we are on the right page. Okay, and then anything else? Do you do any prescriptions, any med rec, anything like that?
No, nothing like that.
Okay, perfect. Good. So I think we've covered all of that.
One thing that just kind of popped into my mind when there were
Yes.
some questions about the measures that are being used,
Yep.
that's not in REDCap. Sometimes I use something called the PCL5, which is a PTSD checklist.
Okay.
And sometimes, and I don't know, Alex, if you want to chime in, but I may use the MOCA as well, which is a brief cognitive screen.
Yep.
I just wanted to mention those two measures.
Okay.
Yeah, awesome. Thanks, Andrew. Yeah, I'm actually still in the process of getting certified in the MOCA, but that is something that I would be interested in having on there.
Okay. Perfect. And you don't do any of your own scheduling, right? Grace does all of your scheduling as well, Dr. G?
Correct. Yeah, that's correct.
Perfect. Okay, is there anything else that you can think of that you document currently that we need to account for?
No, other than the templates that I sent to
Yeah.
Lily. Yeah.
Perfect. Okay. So general clinic information, we kind of understand a lot of this information. Are we missing any other people that work in your clinic besides the ones that we've mentioned or that are already attending here? There's no other specialties that work in your clinic, right? Good.
Wait, we did have a pharmacist for a while, and it's possible that we would want to try to establish that again if pharmacists are available or funding was available.
Okay, that sounds good.
I should also
there-
mention that we also have psychology residents coming in. I don't know if that's categorized under the medical residents that I see there on the screen, but we also have psychology residents coming in as well.
Okay, yeah, that sounds good. Okay, we can move on to the next slide, love. Okay, so we know about the internal external referrals. We know about the referral triage piece. So I guess this is more going to you, Lana, because you're the initial person with the referrals. So referral comes into the clinic. Does Grace just hand them all to you currently?
Yes, so she does physically, and then she enters it into our sort of a Word document that we created over some time. So yeah, we have pre-surgical and post-surgical referrals as well.
Okay, are they differentiated current state?
They
Whether or
are.
not they're pre or post?
Mhm.
Okay, does that make a difference on how you triage?
Yes.
Okay. So do you need that
In terms of the
separate?
priority, sorry, just in terms of the priority as to what I attend to first. But in terms of the
Okay.
process as to how I do it, it's pretty much the same. Yeah.
Okay, but going forward, you would like to know which ones are pre and which ones are post. That's important
Absolutely.
information to have face up.
Yes.
Okay.
Mhm.
Okay, so you get the referrals, you see which ones are pre and post, and then which ones do you triage first?
Post-operative clients.
Post. Okay.
Mhm.
And then based on that list, it's just you who's doing the triaging. You're the sole one nurse, right? You're not
Mhm.
sharing this responsibility with anyone else. Okay. So then you work off of that list, and then
Mhm.
the first step, is it screening the chart, or is the first step the phone call?
Screening the actual referral form
Yeah.
chart, and sometimes connecting with clinicians or referring clinicians.
Okay.
And then it is contacting the client themselves. Yeah.
So does Grace automatically book all of these patients for a phone call, or do you screen them first, do the priorities, and then let Grace know which ones you want booked?
That's correct.
Okay.
Yes.
Okay. So then you have those booked, you do the phone call. Are you currently documenting a standard form right now when you do these phone calls?
Sorry, I'm just going to clarify that Grace
Yeah.
does not book triaging calls. I actually
Oh.
call them. That's correct. Yeah.
Oh, so they're not scheduled currently. You're
They're
just
not currently.
working off the list and you're doing the
That's
phone
right.
calls and you don't need that scheduled. Do you want that scheduled in the future? Is there any requirement to have that scheduled, or is working well doing?
I would like that to be scheduled,
Okay.
just to kind of help with organizing my time, but I'm not really sure. This is something we can talk about, I guess, as a
Yeah.
team.
Yeah, or even we can show you in the design process later on kind of what that would look like, whether the clerk does that work or whether you do that work, because you would have
Okay.
the ability, if we give you the position, to be able to schedule your own telephone visits as well.
Cool.
So
Yeah.
we can talk about that a little bit more in design and kind of show you, and you can kind of let us know. So you do the telephone, and then sorry, did you say there was standard documentation for the telephone phone call, or do you just kind of like write a narrative note right now?
Yeah, I created templates for pre and post triaging,
Okay.
pre-surgical and post-surgical clients. Yeah.
Okay, so we'll probably reach out and grab those from you.
Mm-hmm.
And then in that screening, do you do anything else? Do you give the patient any other information or do anything else in that screening?
I don't provide anything other than the information about TPC. Mm-hmm.
TPC is
Like
just
our
about the
clinic.
clinic.
Sorry.
Just
Yeah.
about the clinic. Yes.
That's
Okay,
correct.
good.
Yes.
Okay, perfect. And then after you're done your telephone screening, is that the point that you communicate to Grace and say, like, I think this is what they need, or?
Yeah, that's correct. So I'll print my form, attach it together to a referral, and then I'll
Yep.
physically hand it off to Grace. And then the Grace books the clients according to my notes.
Perfect.
Or,
okay.
Yeah.
And then once you're done that referral triage, that phone call, do you do any other follow-ups with the patient, or are you done at that point?
So then Grace is going to book an appointment
Yes.
first with myself as a telephone intake, and then with the physicians. So then that's my second time connecting with the client, which would be the initial interview with either pre or post-surgical clients. And those interview forms, I've created templates myself that I can just share with you as well.
Okay. Okay, so you do the screening, which is not scheduled. Then you actually get the phone call scheduled. He's like, Grace, no, I want to actually see this person. We'll do the phone call. Grace books the
That's
phone
right.
call visit. You do that
Yes.
phone call actual intake.
That's right.
And then from there you say to Grace, hey, I think this would benefit from Dr. McGrath or whoever you might think. And then you let Grace know who to schedule with. Is that how it works?
So after the triaging, so after the very first time I triage the client is the time that we decide whether the client is interested in seeing us. And then
Yep.
Grace will offer 2 appointments. One is going to be first with myself and
Yep.
then with the pain specialist that I recommended or suggested.
Okay, so they're booked at the
decided.
same time.
They're booked at the same time, not on the same date.
Yes.
I typically see them prior to the physician. So the physician
Okay.
has the ability to review my notes and
Yep.
then goes into the intake with them.
Got it.
Yeah.
Perfect. And then do you ever reject referrals, or I guess have people that don't want to
Yes.
proceed? Okay.
Mhm.
And then do you just communicate that with Grace, and then does Grace contact the
Yes.
referring provider?
Yeah, that's all included in my triaging template that I created that I will
Got
share
it.
with you. Yeah.
Okay.
Hmm.
Okay, so that is all good. And then so besides, so you do the triaging, the initial phone call, the intake, is there any other follow-ups that you do once they've moved on to the other providers? Do you continue to follow these patients at all?
As per clinician's request and also
Okay.
clients. Sometimes clients will call me for different reasons. Yeah.
Okay, but you're not keeping a standard list that you have to always follow up with these people.
No, no.
Okay, perfect. And then if people do call you, do you have a standard documentation for that, or is that just like a free text when
It's more so a free text. Yeah.
Okay.
Yeah. The other thing that I do that I created a template for is that currently we do attend to one of our pain surveys includes the suicide type questions. So I do have a PHQ. It's called a screening template that I created, but that's on a table right now as a team. We're discussing whether that's going to be shifting or changing. So I guess
Okay.
I'll give you a little bit more information about that after that. The other thing that I do is the med rec. So that's during the initial intake.
MedRec or a BPMH? Like, do you do the best possible medication history?
That's right.
Yes.
That's
Perfect.
correct.
Yeah. Okay, so that's good. Is there anything else? And you don't schedule your patients currently, that's all done by Grace, so we don't need to worry about that.
Yes.
Okay, I think we've asked all of the questions and we understand how it's communicated back. Is there any more questions on these slides? Okay, so I think we've gathered, and you don't give any medications, you don't do any of that kind of thing. Is there anything else that you can think of that we need to be aware of that you do? Okay.
And what about group classes? Did we talk about that at all?
We have a case conference slide coming up, so we'll
Okay.
definitely get into that. So once the patient's done, so we've kind of gone through each of the roles of different things. We'll get to the case conferences. When the patient is ready to be discharged, who initiates that multi-contributor form? Is it just the first person who feels like they're cleared from their end? Okay. And then I guess, is it the responsibility of the last person to fill out that form to know that the discharge is done, or How is the final discharge followed?
What you just said there at the end. So the final person who is filling out that report,
Yeah.
take care of that. And then there'll also be an email out to the team from each
Okay.
of the clinicians involved to let them know, hey, I'm done this section of the report.
Got it. Okay, and then that final person, is that the person who provides the discharge package to the patient?
Yes, and that person will notify Grace, who will then initiate the full discharge from the clinic process.
Perfect. Okay. And that discharge process is the discharge package and then just discharging the actual patient from the clinic, right? Is there anything else that needs to be done for that discharge?
Correct so far, but maybe I'll let Grace or someone else step in who knows a little bit more about that.
Sorry, Grace here.
Hi, Grace.
For the discharge process, so basically once the client has been discharged totally,
Yeah.
meaning medically discharged and discharged from the allied health as well.
Yeah.
So they notify me and I process the discharge. So basically it's one, sending the discharge summary with interdisciplinary reports to the GP. Two, sending email to the patient, notifying them that they've been discharged. Three, sending them the survey link, which is a discharge link from from RedCap. Yeah. So and then after that, we just wait for the patient to complete the discharge survey. And then once I print that out and Lana signs them off, and that's it.
Oh, what do you mean by Lana signs them off? Lana looks at them?
That's right. I do that for the surveys when they are initially taken by clients, completed by the clients. I sign them off, and then when they're discharged as well, and they go to the chart. So yeah.
So does that mean you look at them and you put them in the chart, or do you
Yes.
document about that as well?
I just sign them off.
Okay.
Presently, that's what we're doing right now. Yeah.
Okay, so that means you print them off of RedCap and put them in the chart, and then
That's correct.
considered done. Okay.
Yeah.
And then if there's anything that's alerting from there, then I guess you would do any follow-ups. Is that kind of why you're looking at them?
That's correct.
Okay. Perfect. Okay, and then so generally what we know about your clinic is you don't do any add-ons or walk-ins. You don't armband them currently. And then the patient comes straight to your clinic, right? Like they don't stop at Central Reg or anything. They come straight up to the clinic. They probably see, is it you, Grace, who they see first?
Sorry, can you repeat that again?
When the patient just comes in, they're going to walk into the clinic. They see a clerk first, right? Like that's their first point of contact.
Yes. So basically they sign into me first. Yeah.
Okay. And then so when you're doing the scheduling, so it sounds like I understand you scheduling Lana, and then when they're actually doing the in-person visits, are you scheduling those people right now to a specific room? Or are you scheduling them to the provider?
To the provider. Yeah.
To the provider. Okay.
Mhm.
Do you have more than one room in the clinic where you see people physically?
Yes, they well, basically the clinicians and the allied health, they all have their own designated rooms or desks.
Okay.
Yeah.
Okay. So we might just reach out to kind of get a little bit of those requirements, or it might be done in the scheduling session of what those rooms are and what you want those titled, and just so in the system you kind of know what is what. Okay. And then I think we understand the types of appointment types you require. Chart prep. When you do the chart prep, is there anything that you're pulling together, Grace, specifically?
Yes. So basically chart prepping starts from gathering patients if it's a post-op patient, so gathering their discharge summary,
Yeah.
their operative reports, and anything that is necessary, like diagnostic reports as well. And then surveys, MedRec, printing those off, the RedCap opioid tracker, nursing notes, and yeah, and then there's a flow sheet that we use where we write down who is the patient booked for, and some demographics. Yeah.
And then are you grabbing all that stuff from Care Connect right now?
Yes, Care Connect.
Okay. Okay, that makes sense. And then we heard the patients are seeing kind of max over a 6-month timeline. Is there who determines, I guess, so obviously if they're done ahead of time, you have that multidisciplinary sheet and that's how you know they're going to be discharged. Is it like a hard 6 months? And then they're discharged automatically, or is it kind of reassessed in 6 months? Okay, so there's no hard 6-month rule. Okay, perfect. Maybe we can go to the next slide, love. And you guys don't have MOAs, right? Just clerks. And then Grace, do you also cover other clinics? Do you schedule for other clinics?
Not scheduled, but I'm trained to like jump in and help out with other clinics if needed, but not.
Okay, so you're not, it's not part of your regular role, but you're
No,
kind
no,
of just cross-covering if required.
Yeah, it's just.
Is it the gender surgery and hydrocephalus?
Yes, that's
clinics?
correct. Yeah.
Any other clinics that you cross-cover?
Sometimes if it's clinic closure and I want to work during those time, I get deployed somewhere else like SOPD or diabetes, but it's just mainly like minor duties.
Okay, and SOPD is another clinic?
Yes.
Okay, and diabetes clinic. Okay, sounds good. And then you don't do any recurring appointments, right? There's never a standard appointment that you're going to book every week for the next 6 weeks, for instance.
I do subsequent appointments for Dr. G, like wherein the patient can book 3 in advance, like either it's like every week or every other week.
Okay.
Yeah.
Okay. And then we heard that you can coordinate interpreters. That's something that you do help coordinate?
Yes, we do have a PLS account and we coordinate that. Okay.
For the interpreters, no walk-ins. And then it sounds like you're reading their notes, eh? You're reading Landa's notes, you're reading OTPT, everyone kind of notes to kind of see what you're booking.
Yes.
Okay. And then the follow-ups, it's the same kind of thing. You're reading their notes to see if they need a follow-up and what you need to book.
Yes, yeah. Same with the clinicians. I do kind of go over it, make sure nothing is missed, because sometimes it gets, they don't put it on the order sheet. So I kind of go through it and make sure that, any orders are not being missed, like urine drug screens or referrals.
Okay. And then you said the system that you use to book the interpreters, what is that system again that you're utilizing? Is it
PLS,
a phone call or
it's the Provincial Language Services.
Oh, okay.
Yeah.
Perfect. And then do you have the 3 no-show policy? So if they no-show 3 times, what's your process for that, Grace?
So basically we kind of keep an eye on a patient, like if they missed an appointment 3 consecutive times, I think, then we will try again and send them an email, say you have this timeline to get back to us. If not, if you don't hear from you, then they'll be automatically discharged.
Okay, and how are you tracking the no-shows now? Do you have an Excel or something that you're keeping track of how many times, or?
We're not having those patients right now.
Okay, so it's not a huge problem.
But it's a good idea to have a tracking sheet for that. Yeah.
Okay.
Well, sorry to interrupt. I was just going to say, but we do mark them within a chart, right, Grace?
Yes,
You do
yes.
That, so,
it's in the flow sheet.
It's in the flow sheet.
Yeah.
Oh, okay. So you do keep
That is
track of it.
Yeah, we do.
Okay. So that's good. I'm just gonna quickly screen this. Do you do appointment reminders right now? Do you send out a reminder that their appointment's coming up?
Yes. So basically, mostly because some of the patients are booked in Zoom, so they get 1 call reminder to an email reminder as well.
Okay.
Yeah.
And
then mostly calling in and
you
sending
call
email.
them.
Yeah.
Okay. And then so if the person's ever rejected, like Lana or someone says, we're not going to see this patient in the clinic, they're not appropriate, do you have a standard form that you send back to the GP, or how is that communication done? Or the referring provider?
Yes, we do have a standard letter, like it's called a declined referral. So we use that.
Perfect. And then do you have any other standard letters that you utilize in your clinic? And what I'm thinking for, it's good to have them for our perspective, because we can put them so you can print them off easily.
Yeah, there's quite a few, like the initial GP letter that we send out together with a consult. There's I was wondering as well, because we have that checklist that we use for discharge. I could send that to you as well. And then the discharge letters.
And the discharge checklist is what?
It's basically for clerks to go
Yep.
step by step how to process discharge.
Okay. Okay. So
Like-
it's more like a working document. It's not clinically
Yeah.
relevant to the chart. It's more just making sure that you guys have completed all your steps.
Yes, yeah.
Got
So
it.
like it's like ending the account in PCIS, making sure
Yeah,
that the
got
letter's
it.
been sent to GP, discharge surveys completed. Yeah, sort of like that.
Got it. Yeah, that makes sense. And then do you ever need, for any of you, documents or stuff to be available the same day? So what I'm saying is, oftentimes, I don't know if, do you keep the paper chart currently till the end of the full process of the patient, or do you send it down to health records before that?
We keep them. Yeah,
keep the
until
chart until
they
the
they are
end.
totally discharged, and then we don't send them to health records. We send them to Iron Mountain. We have
Oh.
our management had set up our own storage with Iron
Oh,
Mountain.
okay, Iron Mountain's a storage place. Okay.
Mhm.
And then going forward, so what I want to see is if you guys need a single document scanner. So what that means is sometimes if there's any kind of loose paper charts or any kind of forms or anything like that that's going to stay on paper, if you require them to be in the system right away. So sometimes it works well if, say, you're doing a nurse visit, then you're doing a provider visit, and the provider wants to see any kind of paper stuff that the nurse is doing. And I'm not talking about stuff that we're going to build in the system. I'm talking about anything that stays on paper. If it needs to be in the system and not physically on paper, a single document scanner is nice because then you can scan the stuff into the system and not wait for health records. If you have that paper chart, if you carry it through the process, it can stay on paper. But if you send it down to health records, they take over 24 hours to actually upload the documentation into the chart. So I'm just trying to gather requirements if you guys want a single document scanner in your clinic to be able to scan those papers in.
Hi, it's Tiana. Can you hear me?
Yeah.
Yeah. So in most clinics, we did not go ahead with a document
Okay.
scanner, but in this clinic, the reason I think that they might need one is because REDCap will obviously continue.
Yes.
I'm assuming that there's probably no way to connect REDCap to Cerner, or that they're not already connected, in which case the surveys will probably have to be printed out and then potentially scanned back in. So I think for that reason, they should have one.
Okay, does it need to be in color? You're not doing anything in color, right?
No, I don't think so.
Okay, and there's no pictures or anything like that?
No.
Okay, so we can request a single document scanner for you guys.
And sorry, Amanda, can I ask,
Yeah.
kind of like the outcome measures that are kind of one-off, I'm guessing those will have to be printed and done by hand, right? They won't be built into the system.
You're talking about the different screening tools that you guys use?
I'm talking about like more of the outcome measures, like for physio, for example. Because I
do
know
you-
when I've used it, like in other, like Lionsgate or St.
Yeah.
Paul's, we've had to print it off. We can't fill it in Cerner itself.
Okay, yeah, I honestly don't totally
Yeah.
know that answer. If Andre
Yeah, hi
is in, do you
guys,
know the
Andre
answer?
here. Yeah.
Yeah.
So most of the outcome measures, they're going to be printed out, but there are some already built in the system. As an example, we are moving forward with the Berg balance, and there is the clinical frailty scale. Some of them will be there, but most is still on paper and will be printed out.
Okay, thank you. Yeah, so that would be good to be able to scan them in then. Okay, thanks.
Okay, yeah. So we'll do the scanner for sure. And then Tiana, reports. I know you said you have what you need for the current reports that are built in the system. Do you know which ones you're going to use for this clinic?
I don't know what they're called in Cerner, but
Okay.
we generally just pull the same like patient volume reports and things
Yeah.
like that. So
Okay.
I know the ones that we previously used just from our previous go live, they
Yeah.
are available in Cerner.
Perfect.
Mhm.
Okay, we can go to the next slide. Okay, and you don't do any procedural sedation because you don't give any meds. So I think we've covered that. Lana, are you documenting, or is anyone here documenting allergies or med histories or anything like that? Okay.
That is included in the chart once when Grace assembles the chart. So
Okay.
currently we do have the space for that, but
Okay, so we'll show you kind of how to document allergies when we do our demo. It's a little bit different because then that kind of sits on the overall chart, not just on the clinic chart. So we can show you that. Okay, and then we talked about, does any one of you do extra random phone calls that you need to have scheduled, or extra random phone calls that you document on besides Lana? I know people call you randomly. Does anyone else?
Physicians would do that too. Sorry.
Physicians will do that too. Okay, did you require those to be scheduled, or you're just comfortable documenting?
I think it'd be more like we're just, going to do that and then dictate a note, like it might be after work, or Grace said, called us or texted us that so-and-so wants you to call them.
Okay, and they've already been seen at some point by someone in the clinic, right? They're
Yeah.
if you're going to do the ad hoc. Okay, perfect. So I want to make sure that they're in the system.
Yeah.
And I would do phone calls as well. I probably like that too.
Okay.
Yep.
Did you need yours scheduled, or it's the same kind of thing? It's okay to call them and document?
Sometimes Grace does schedule them.
Okay.
And so it's both. Sometimes I just call them, but sometimes they get scheduled. If it's like, okay, check in 2 weeks or something, she'll put it in
Yeah.
there just so that I'm aware of it.
Okay. And then Tiana, these like different visits and stuff, do you get funding based on how many of these visits you do? Like, I'm wondering if you want them scheduled in the future.
Sorry, do we get funding for them?
Yeah. Like, is your funding at all based on the amount of these phone calls and different things that you do? Like, do you need this tracked at all, or it's okay to just kind of do some of these ad hoc phone calls?
I don't know about the funding piece, but I mean, ideally we want all appointments, trackable, so that we
Okay.
can get that data. Just because I don't know for sure that there won't be a time where someone, is curious, the ministry wants numbers or something like that. So it's good to have it in case we ever need it.
Okay. Okay, we talked about the ad hoc phone calls and we talked about scheduling appointments. We can go to the next slide. Case conference. So we hear that you guys do case conferences and we hear the patient's not present. Is everyone OT, PT, anesthesia, nurse involved? Psych? Are you all involved
So
in the case conferences?
it would be yes, and then the clinician or the physician involved is the one, like we have a separate case conference for each physician, so it would be typically the patient that they're following.
Got it. And then who coordinates these case conferences?
Well, we just started, so I guess Grace is kind of putting the list together, but anybody could add someone to the list. So let's say it's, Sarah is like, I really think we should talk about this patient, and I hope we can talk about it in our next case conference with Dr. Chan. Or I might say, hey, I want to talk about this patient. And then we would let Grace know. I think that's how it's going, Grace. We just started these, so it's kind of like a thing in motion. But Grace, I think you're putting that list together. She might have had to take a phone
Grace?
call or something.
Yeah, I think you're just on mute, Grace.
Oh, sorry. Yes. So
That's okay.
basically the case, sorry,
That's
the
okay.
case conferences, it is scheduled individually with the clinicians, and then they have their own days that is scheduled within their clinic times. And then most of the clinicians will let me know who they want to add in the case conference. And we've created that template, like Word document, where we put in the patient's information, and then each clinicians will add some information, what they want to tackle in that case conference.
Okay, so basically, one of the clinicians is requesting it through you, Grace, saying I want the case
Yes.
conference, and these are the people I want involved, and then you're reaching out to those people to kind of get a running document of what will be covered, like a agenda for that case conference. And then do you schedule all of these people to the case conference, or how does that work?
Yes, we will. We kind of just put in whoever they want to discuss on that Word document, and then go from there.
Whoever they want to. Oh, could it be multiple people?
It could be
multiple different-
well, yes, yeah.
Okay. And then is there
Yeah.
documentation that happens at that case conference?
That's what we're working on.
Yeah, we're just working on that. We at first thought it'd be kind of organic and we'll just make our own notes, but we're experimenting with a Word document to just sort of keep track of what was decided and action items.
Okay, and are you hosting those case conferences in the clinic? Like, do you schedule them to a certain clinic room?
We schedule them so that all of the clinicians who are going to be free, so their time is blocked to have the case conference. And we've just started doing them in person, but with a Zoom link available in case like the physician can't be there or something.
Okay, if they're in person though, is it in the clinic?
In person, yeah.
Okay. Sounds good. Okay, so I think we covered how it gets scheduled. I think you're still working on the documentation piece. Is there any chart prep that you need to do, Grace? Do you pull anything for these besides that running document of the agenda?
No chart prep needed. I just pull out the chart and give it to Lana.
Okay. And then how are people contributing right now for adding to the agenda? Are you emailing this to people, or like how are they filling out this Word document right now about what they want to talk about?
We
The-
just
the
have
Word-
oh, sorry,
yeah.
go ahead, Michael.
No, sorry. The Word doc, we would just fill it out as we're there. And
Got
in
it.
advance, it's really just these two patients. Like it's just an.
Got it. Okay, so you're not doing any other documentation in advance. Okay.
Not really. Correct me if I'm wrong, team, but that's kind of how we're doing it right now.
We do have a list on the G Drive, and we add names ahead of time, and you can add some points, and then we have like that list to go off of when we get to the case conference.
Okay, so you're accumulating a list, and then you do the actual case conference.
Mhm.
Okay. Anything else I need to know about case conferences? Okay, moving on. We talked about research. You're not doing any research currently. Additional questions? Is that the end of our presentation, Love?
Yeah, that's the end of the questions that we have for the clinic, and this is just if they had any questions for us.
Any questions for us, or anything else that you think is pertinent that you're coming up with, that you're working on in the background that we would need to help facilitate in the system? Lana?
Oh, sorry, Lana, you're mute.
Sorry about that. Hi. I just wanted to know if there's a date by which we need to submit these templates of forms that we're currently using to you.
So we'll email you and kind of ask for what the different forms and stuff like that. So then you know the key person to email back. There's not a specific date, but what we're hoping to do is in probably 2 to 3 weeks, bring you guys back and kind of show you what the options are for what you can document with what you've given us. So we need kind of a few week window to actually review it, kind of prototype stuff, so that we have something to show you. So if it's possible, the sooner the better, basically, because we kind of have to go off of this. Once we receive the documents, then we can start working on it. And basically, I think, Dolores, you can correct me. I don't know how we have 2 other design sessions on the books and a validation session. I don't know if we're going to require the 2 other design sessions. Once we gather all your forms and see how much build there is, we might get away with just 1. But yeah, we're hoping to have, oh, Dr. G says they also have group classes. Dr. G, are those similar to the case conference and how they're coordinated? Or is the group classes with patients?
No, the group classes are with patients, so they're separate from the conferences. So Sarah mentioned that earlier, I think.
Okay, and the group classes, are you coordinating those right now?
What we'll do is, so the group facilitators will notify Grace as to when we can have the classes. So right now they're on a monthly basis. And then patients would be forwarded an email with the invitation, and then they'll join. And then I will take notes on attendance and participation for each of the folks who attended the class. And then there's also surveys that are given to the patients during the Zoom class. And then I kind of document how folks scored on that, but it's an anonymous survey.
Okay, and then are those being held in the actual clinic, in the transitional pain clinic, these classes? Or they're being held somewhere else?
Yes, virtually, yeah.
Virtually.
Mhm.
Okay, and then are you the only one who coordinates these classes?
It's a work in progress, but right now it's myself and 2 physicians. So Dr. Butterfield leads one, and then Dr. Meehan and I lead another. And the rest of the team, I think, are kind of working on building different classes for the clinic.
Okay, but all different physicians will communicate to Grace saying you want to add these certain patients to this class. They occur on a monthly basis, on a recurring basis. And then you go there and you do documentation based on the one class visit.
Yes, that's right.
And then do one of you physicians like Grace know when the patient's no longer going to come to the class anymore, or?
They're just kind of standalone classes, so there's no need for any follow-up after that.
Okay. Okay, and then are they invited to multiple classes though, or you're saying the patient comes to the one class? Like, are they coming every month, or is it just like supposed to be a one-time thing that they come to?
It's a one-time thing, but patients
Got it.
are welcome to attend again if the class is offered.
Perfect, thank you.
And
Dr.
there's
McGrath?
more than one type of class. There's 2 right now, but we may add other classes in the future.
Got it. Okay, and is there different documentation that you guys utilize for the different classes?
Yes, so I use a group note template, and I think I forwarded that off to you.
Perfect. Okay. Okay, Dr. McGrath, did you have anything else? Any questions or anything else to add?
What happens when clinics 6 months down the road change their processes or want to change stuff?
So that would be sustainment. So you'll go live with the clinic, and then it would go through a sustainment process in which you would submit your request. So you will have site CISs that kind of like stay back on your site that are informatics role by background. So you'd submit your request kind of through the regular process, and then things would get reviewed, and then if appropriate, they would get built kind of through that process. So yeah, definitely you're not, it's not a one and done. You're not forced to do the same thing forever. Yeah.
Okay, thanks.
Yeah, but if you have anything coming up, let us know so that like prior to go live so that we can accommodate that. So when you go live, because it takes a little bit of time to actually change stuff in sustainment. Your best bet is to get it built now. Perfect. Okay, so we'll get the forms together. We'll aim for in a couple 2 to 3 weeks to meet back up to kind of show you in the system what the possibilities are and kind of work with you to see what you want in the system, what you don't need in the system, and what is the best route to get that information there. And then once we're done that, we can determine if we've gotten through everything and you're happy. If we need another design session, if there's a lot of stuff you want to change, we can follow up with another session. If you're pretty happy with after that design session with the stuff that you see, then we could just finish building it properly and then do a validation session. So we'll kind of see after the next session how many more times we need to meet. But we will get someone to reach out to you to gather all of those forms, and then we'll start from there. In the meantime, you have Lavalia and Dolores. We'll put them both on the contacts. If you have anything that you think of or any other things that you want us to consider, you can email them to. Yeah, is there any other questions about?
So just to add to that, we will have a scheduling session coming up soon. Brian West is going to work on scheduling that. So yeah, so that'll be scheduled soon. We're just looking at dates because this one got moved up. So we're going to try and move the other one up as well. So stay tuned for that. Not all of you will need to attend, but we will be sending out invites once we're ready to go with that.
Yeah. Yeah. So next step, we'll show you the general kind of stuff in the system. And then at the end, we'll actually show you the stuff that we've built that will be more specific to say your clinic. So yeah, thank you. We super appreciate your time. This is really helpful. Gives us an idea of where to go off of and what we can show you next as your proposed future state.
Great. Thank you, Amanda and all. Thank you.
Thanks.
Thanks, everyone.